All right, for this lecture, we'll be talking about cardiac diagnostic testing. We'll go into these results, these diagnostic tests, a little more in depth in this presentation than we will in your other cardiac specific presentations. I will still cover the majority of these topics again. However, I would say that just to make sure that you're getting all the information that you need to review this video as well. So I'm going to try to cover just the basic diagnostic testing, and we'll talk about what we might see and what we might do for those clients that have abnormal values. All right, so obviously we can start off with just our normal lab values that you're going to see every day regardless if it's a cardiac patient or not. So when we think of our CBC, we think of, hey, we're going to look for any indication of ongoing infection. We said that infection or sepsis or things along those kind of same processes can be problems for us because they cause vasodilation and they can have an effect on our cardiac output. The same with anemias. Obviously, we are losing the ability to carry around oxygenated blood. We don't have enough red blood cells to be able to transport what we need, and your body is going to try to compensate that. And we said initially it will probably be seen as a tachyarrhythmia. So we can look at other blood disorders, blood dyscrasias as we go along. We'll kind of talk, but briefly. I don't want you to get lost too much into things that aren't as cardiac specific, because that's probably, if it's a cardiac question, it's going to be something that relates mostly to the cardiovascular system. We do know one of the things that I always want to look out for is this thrombocytopenia, which is a low platelet count, because we do tend to give a lot of medications that cause thrombocytopenia. Specifically, in my case, for this content, diuretics and anticoagulants heparin. So we'll look at our normal lab values. So you remember WBCs are 5,000 to 10,000, but we also recognize that a fever will increase the workload of the heart. If you have an active infection, so you have massive vasodilation, your heart's wants to speed up to maintain adequate tissue perfusion, and that's going to require more oxygen for that heart to be as effective. Red blood cells, honestly, hardly anybody talks about red blood cells. They're important. We want to make sure that our numbers are somewhere in the 45 to 6,000 range. But for us, mostly probably what we're going to look at is hematocrit and the hemoglobin. So I want us to kind of remember ranges. I don't care about male or female. If I can remember that, generally speaking, my hematocrit is somewhere around 50 to 52, 40 to 52, then I'm okay. And I don't have to really investigate further. We know that as our clients get older, they are going to have some changes in their hemoglobin and hematocrit. So the same can be said for our hemoglobin here. I kind of try to remember that 12 to 18 number. Both of those I recognize that the bottom number is geared more towards our female clients, and then the higher numbers are geared more towards the male. But like I said, every client is going to be different. Body surface area, other disease processes, other disease comorbidities, whatever it may be. I think it's important that we recognize that when I am looking at my hemoglobin, hematocrit, my H&H, that I recognize that there should be a 3 to 1 kind of ratio from the hematocrit to the hemoglobin. So if my hemoglobin were 15, I use 15 because it's a nice, easy number, that's my 1. I would have an expected hematocrit of about 45. So it's a 1-to-3 ratio. If you don't, again, you could have some issues with hypovolemia, hypervolemia. Sometimes, if we lose some of that volume, some of the plasma, if it shifts to the interstitial spaces, and you have edema associated with heart failure or PAD or PVD, then you can have changes, and that blood can become really thick and viscous, which would make it harder for the heart to work. So that's why it's important to recognize that 3-to-1 ratio. And again, we've talked already about platelets. Normal platelet count is 150,000 to 400,000. That's pretty straightforward for most of us. For electrolytes, we're going to look at our sodium, potassium, magnesium, and calcium. Sodium is going to be more geared towards just homeostasis and kind of maintaining that natural balance. I would not say that sodium is something that you would see on my cardiovascular test, as I tend to gear more towards the potassium, magnesium, and calcium. So I do want you to notice that if we are talking about hyper or hyponatremia, you are still seeing things that are going to affect the cardiovascular system. So if I have too much salt, you can have issues with too much blood volume, which would cause hypertension, and that hypertension would put you at increased risk for heart failure. With hyponatremia, you can have cellular swelling, which could lead to rupture, which would change your potassium, serum levels. But the big one is arrhythmias and decreased cardiac output. So we can see top one, hyper, I have increased blood pressure, I have increased blood volume, and increased risk for heart failure. Hypo, I have the issue with arrhythmias and decreased cardiac output. So it's high and low. Potassium will probably be the one that you see or have the most trouble with. We tend to give a lot of K-runs. So hyperkalemia can have a profound effect on your dysrhythmias, or on your rhythm, I should say. It can cause bradycardias. It can cause peaked T waves, which you're probably never going to see peaked T waves because of potassium. But it is a documented and well-researched outcome from having hyperkalemia. You can have heart blocks, which that's what it's talking about when it says the prolonged PR interval. You can have chronic widening of the QRS. You can increase your risk for asystole and VFib, which are both very bad. With hypokalemia, it's kind of the same. You have an increased risk for arrhythmias. You see some of our ectopic beats here, so PVCs. Don't really expect my new graduate nurses to look at or understand what a flattened T wave or what a U wave are. So I would be more concerned that you understand that you are at increased risk for dysrhythmias. Magnesium and potassium kind of go hand in hand. And again, I'm still looking for a baseline number. If I know if I'm going to keep this number between 1.5 and 2, I'm okay. With hypermagnesium, again, you see bradycardia. So now you see how these two things link together. And decreased cardiac output, so hypotension. You still see the prolonged PR interval, and then you see the dysrhythmias. Cardiac arrest is obviously a severe case of dysrhythmia. Hypomagnesium, again, arrhythmias, including this one called torsades de pointe. We'll talk more about torsades de pointe when we're talking about our dysrhythmias. It's a polymorphic ventricular tachycardia. It's twisty and turny is the way that they're going to talk it. And you'll see changes in your 12-leader and your telemetry monitor. So we know that dysrhythmia can be corrected by giving magnesium. And when I think about this, I always think, it's our clients who are coming in for ETOH. So hypomagnesium can also exacerbate hypokalemia and hypocalcemia, which are going to make it worse. For the calcium, we see that number is 8.5 to 10.5. Again, it depends on which book that you look at. But with hypercalcemia, you can have a shortened QT interval. Again, you see arrhythmias and an increased risk of digitoxicity. Again, calcium is something that helps protect the heart. So if you have low calcium, you're at increased risk for those add-on effects of the medications. With hypocalcemia, you can have still prolonged QT interval, so it's kind of the opposite of the hypercalcemia. You still have decreased cardiac output and increased risk for heart failure. From our perspective, if I'm going to give you something, say I'm going to give you the magnesium, and I tell you that their mag is low, we're not going to put something like 1.3 as our number for magnesium, right? Any laboratory value that we give you should be noticeable, and if it's not noticeable, it should probably include a reference range. And we know that a lot of our next gen NCLEX RN questions will give you reference ranges now. Okay, for our coag studies, PT, PTT, they're okay. We don't typically look at those a lot, but we do look at the APTT, so the activated partial thromboplastin time. That normal is going to be about 30 to 40, and that's for me and you. We should be somewhere around there if we were to have our coag studies drawn. For somebody who's on heparin, either DVT, PE, whatever it may be, we want to see them be more therapeutic. So we're looking at a number that is basically 2 to 3 times 1.5, 2.5 times. Doesn't really matter which way you remember it for both. You want them to be therapeutic. And again, I think this is something that if NCLEX is asking, or I know 100% for sure if I'm asking, it's going to be a number that's going to be outrageous. So if I want you to understand that this client is bleeding out because they're on a heparin drip, then I'm going to give you, a number like 200. And you should know what to do if their PTT is 200 and if you don't. Now that's not a problem because we're going to talk about it when we talk about PEs and DVTs. I know you know, so just as a reminder, we know heparin because our 2 T's make an H. They're like small T's that are connected together. The INR itself, normal should be 1 second. Again, that's you or me. And therapeutic is 2 to 3 times that. We still understand that anything greater than therapeutic is increased risk for the client bleeding. So you have to pay close attention to this number. A lot of our clients who are on heparin will then get transitioned over to warfarin or to one of our direct oral anticoagulants, which we will see kind of later in some of the lectures. They are just now making their way to NCLEX RN, but we'll talk about them. INR with warfarin, we understand that because I'm on heparin and because it takes time for warfarin to start, that I'm probably going to have them taking continuous heparin infusion with some PO warfarin until they become therapeutic on our INR. I think we probably remember our antidote. So warfarin, it's just your vitamin K. So we can also do FFPs because they contain clotting factors. For heparin's antidote, we're looking at protamine sulfate, and then generally we're talking about unfractionated heparin, not a low molecular weight heparin, which we see down here. So generally speaking, if you have these really extreme numbers, you can give them protamine sulfate. But probably the easiest thing to do for heparin is that it's going to have you stop the infusion for 1 hour and then redraw that PTT. So yes, we can do protamine sulfate. However, heparin has a very short half-life. This is nice to know information. If you got 1 milligram of protamine sulfate, you can neutralize 100 units. So 1,200 units would be 12 milligrams of protamine sulfate. But it's not something that I would ever ask you guys about. Enoxaparin, or our low molecular weight heparin, it can still be counteracted with protamine sulfate, but it's only partially. And just probably the best thing that you could do there is just hold that next dose. BUN, creatinine, and LFTs, please do not call it a bun. Right? It's a BUN. That I just remember like 10 to 25. I'm pretty good with that. If I recognize that I have a high BUN, for us, it could be indicative of heart failure, shock, hypotension. So it's high and dry. So there are certain medications, such as NSAIDs and ACE inhibitors, but the biggest offender is probably your diuretics, especially since we know that we give the loop diuretics. Furosemide is the one that we'll really give a lot of because it's geared more towards clients that have renal insufficiencies or renal injuries to help take fluid off. If it's low, it's wet and low, or low and wet, however you want to say it. This is, again, overhydration. So this is probably because you had a client with a history of heart failure, and we came in and we started them on fluids at a really high rate, and then we determined that, oh my gosh, they're having heart failure. I probably shouldn't give you all these fluids. And then you can also see changes to that number because of steroids. Creatinine, again, this is a number that I just put as 1 to 2. I try to remember 1, but I know most of my clients who do have like a history of heart failure or hypertension, I know that that creatinine level is going to be elevated just because, again, the heart and the kidneys have such a close relationship. LFTs are kind of going to be more for medication, especially if they're on an amiodarone, which is for ventricular dysrhythmias, even though we give it to slow down the rates in like an SVT or an AFib with RVR. Statins are going to provoke some sort of liver dysfunction as well. Statins we're going to give to break down our cholesterol. And then we have acetaminophen, can do that as well. A lot of us are seeing more use of Tylenol in the clinical setting for pain control, but then you will also see that they have a scheduled medication that may include Tylenol. So just be careful about monitoring how much Tylenol or acetaminophen your client takes a day. CVPs. We've got a nice little illustration down here of kind of what it's going to look like to be monitored with CVP, and as you can probably tell, this is going to be some high-speed ICU stuff, maybe some of your more high-speed step-downs. But this is just a central venous pressure. And what I remember is that, with the BUN, it's going to be directly opposite of what a CVP is. So wet or dry is going to depend on what number we have here. 2 is a pretty low number, so dry can be harder for us. But what I want us to think about is, like, if I have fluids, continuous fluids running, And I have them on this CVP monitor. Remember, this is constant updated information. And then that CVP does not go up, then you have to ask yourself, where's that fluid going? Okay. So CVPs, again, they're going to be done mostly in the ICU. They're going to tell us all about the pressures within the thoracic vena cava. It's geared towards pressure specifically in the right atrium, so it's more about preload than anything. And then you see that it's going to help us assess fluid status, right-sided heart function, and venous tone, which is what we'd expect from something with the name of central venous pressures. So sometimes the answer is in the name. So here's kind of what we see with these CVPs. Anything less than 2, obviously, is low, and hypovolemia, massive vasodilation. You're going to do these things. Monitor their blood pressure, monitor their heart rate, give them fluids. You don't really have to do anything for normal, knock on wood, but for CVPs greater than 8, it means that they could be in fluid volume overload, or they could have a history of chronic, or they could be actually in an acute on-chronic episode of heart failure. So what do? We do what we need to do to get rid of preload. We can give them diuretics, we can do fluid restrictions, listen to lung sounds, because if you have fluid volume overload, where is fluid going to go? It's going to go in the lungs. Troponins are going to be big for us, right? They're going to be indicative of myocardial infarction and ischemia. So I don't like getting too lost into troponins. No, it's not working. My eraser's not working, sorry. So you see this number here, this is 0.04. Forget it. The troponin should be 0. Nobody walking around who is reasonably healthy should have an elevated troponin. When I do have these higher levels, it indicates either ischemia or injury, and it's helping us develop a plan to care for that client. So we think about higher levels. Again, this is something they're not going to try to trick you on. If it's going to be high, it's going to be high. And you have probably seen the same things I have seen. I have seen troponins that were just through the roof. I'm talking, 15,000. These levels will rise and fall with damage and with the healing process starts. I don't ask you guys any questions about how long or anything like that, because everything is changing. In the next slide, we're going to talk about deltas, just because I want you to be familiar with it, but I don't expect you to remember anything about a delta for the exam. I want you to understand that normal, healthy people don't have elevated troponins. Okay? The only real problem is troponins are cardiac specific, but they can also be elevated in the presence of inflammatory conditions, so things like myocarditis, pericarditis, structural heart disease, coronary vasospasms, so if you're thinking something like variance angina, that can help out. It can help diagnose. And also some non-cardiac specific conditions, but they're conditions that we've talked about already with sepsis and chronic kidney disease. Notice that this is need-to-know information. So deltas are the latest and greatest. They refer to the change, the rise and fall in a patient's troponin level over time. Now, it's much less time than it used to be in the past. We can see down here it's 1 to 3 hours. It's not typically that 4 to 6 hours that we've been looking at before. So what we're going to do is we're going to draw that initial troponin level. We're going to get the baseline. We're going to repeat that troponin And then we're going to look at just the differences between those numbers to help us plan care. So, when I see a rising delta, it indicates an acute cardiac injury such as infarction or myocarditis. Falling delta may indicate that it is a resolving issue. So if your client had an MI, but they were stubborn and did come into the ED for a couple of days, you may see this falling delta. And then obviously, if you don't have any changes, right, it can suggest chronic elevation with kidney disease, heart failure. We're going to call this demand ischemia. We'll talk about that when we talk about heart failure and CAD ACS. So much like our troponins are reflective of an MI, our BNPs, so Bravo, newspaper, and P, because I can't remember anything for P right now. So we'll look at a BNP or a pro-BNP for heart failure or stress. So this is, again, this could be reflective of that demand ischemia, which really all BNP is reflective of that because it's for heart failure. You need to understand that a normal BNP, a B-type natriuretic peptide, is less than 100. There is another one out there called a pro-BNP, and that level is going to be 900. However, this is something that, again, if in NCLEX or if I'm going to give it to you, I'm probably not going to ask you to differentiate between 100 and 900. There is differentiation. We'll look at it. But I'm going to give you an exaggerated number. So they come in, I want you to understand that it's heart failure. I may give you a BNP of 10,000. Something that is well above this 900 number so that we're not confusing. Really what it's going to reflect is this ventricular stretching and ventricular dysfunction or stress. I do that because you have two S's, stretching and stress. In clients who have dyspnea, an elevated BNP may confirm a diagnosis of heart failure not originating in the respiratory system. So it's not related to poor pulmonale or something along those lines. This is a true heart failure. So kind of this is what you would see as far as values for the BNP. So we said less than 100, that's going to be our normal. If you have 1 to 3, you may have some signs and symptoms of heart failure. Greater than 3 to 6, you have mild heart failure. So you could see this documented as a client that has like a preserved ejection fraction, something along those lines. Greater than 600 to 900, moderate, and anything greater than 900 is severe. And I think the severe is where we're going to hang our hat for testing purposes. CK, CKMB, myoglobin, CRP, D-dimers, those are all nice to know things. We don't see a whole lot of them anymore because they're not specific. But with CK, CKMB, normal is still 0. Right? We don't want to have that stress. It's not as sensitive as our troponins in early identification, but the levels do increase with a myocardial infarction. Our myoglobin, we want that number less than 90, right? So, and again, the problem with the myoglobin is it's not specific to myocardial injury. CRPs are more about inflammation, so they could be reflective of CAD, coronary artery disease. D-dimer, if you guys remember from respiratory, it's going to be less than 0.5. So again, I just say 0. And we can get that if we suspect they have a PE or DVT. And again, the problem with the D-dimer is that it's not definitive of this diagnosis. All it is telling me is that there is clotting happening somewhere. Imaging. Imaging is a huge part of what we do. Chest x-rays can be done at the bedside. It doesn't really give me a whole lot of information about the cardiovascular system other than that the size of the heart has changed or I can see pulmonary edema. MRIs, again, we can use imaging using no ionizing radiation. It can be used with contrast for an MRA, so the angiograms. It gives you a 3D picture of the heart. Just be careful, don't wear anything metal when you're going to something called a magnetic resonance imaging. ECG, so we have a 12 lead and we have telemetry. I want us to remember that a 12 lead is that it's 12 different views. I don't care if you understand it's lateral or if it's anterior or wherever the chest pain is happening according to the 12 lead. What I want you to know about a 12 lead is that it's for new or recurrent chest pain. I don't care if you just got one yesterday. If they're complaining of new or recurrent chest pain, you need to get another 12 lead. While you're getting a 12 lead, most of those clients are probably already on telemetry. So the difference between a 12 lead and telemetry is that telemetry is a limited number of views versus with a 12 lead I have the entire view. Telemetry is good, it's continuous, it's ongoing, and I can see changes into their rhythm in real time. So generally speaking, it's a non-invasive test used to evaluate the electrical activity of the heart. It helps us identify heart rate, any kind of conduction disturbances, if there are issues with myocardial ischemia, or possibly structural defects. That would be more typical with your 12 lead, where it's telling you, suspect anterior MI and ventral septal hypertrophy, something along those lines. We're going to look at this ST segment. We will cover this in depth. Don't worry if you don't know what an ST segment is yet. Basically, what we're going to say is this ST segment elevation is indicative of a STEMI, or a myocardial infarction. So it's ST elevated myocardial infarction. I have ST segment depression, which may represent ischemia or infarction. As we get into our dysrhythmia lectures, we will show examples of each one of those. We can examine for atrial dysrhythmias because what we're looking at on telemetry or on a 12 lead is the client's rhythm and time. So that will help us identify PACs, heart blocks, conduction delays, bundle branch blocks, things like that. And this may be because you've had these structural changes to your heart or have a history of heart failure. The great thing about 12 leads is that they're easy to do. They're fast, unless, of course, the machine is acting funny. We need a 12 lead to rule out or confirm an MI. It must be done and read by an MD within 10 minutes of a client's arrival to the ED. We've talked about the fact that our 12 leads are for new, acute, or recurring chest pain. Of course, lethal dysrhythmia should be treated before another ECG is obtained. Generally speaking, we understand that those clients are probably already on continuous ambulatory ECG monitoring. If we send you home with it, it's called 24 to 48 hours. We'll talk more about that as we get into that CAD and ACS as well. Again, this is the biggest thing that my students get stuck with. Telemetry is continuous and is not the same as a 12 lead. A 12 lead is a one-time view. If I took my 12 lead at 12 o'clock, it's only for 12 o'clock. However, the client can probably be on telemetry, in which case if I wanted to see updates or changes, I could look at their telemetry monitor. We want to use telemetry for early detections of arrhythmias, right? For real-time monitoring to help improve patient safety. And we're going to use that information to help guide our treatment decision. So we will give you more examples of this. So this is just going to be like a brief overview. We see changes in this ST segment. So the first thing that we have to understand is what an ST segment is. So I'm going to draw it up here on the right-hand side. So I see I have a P wave. Give this client a Q wave. So that's that downward deflection I just drew. I'll have an R. So I've got P, Q, R. The next line, the one that's going to either try to come back down to this isometric line, is the S wave. So wherever this wave lands is going to be indicative of whether or not I call this ST depression, ST elevation. And I'm going to make that decision based upon something called the isometric line. So this line that the P wave is on, I can see that it should be a straight line. And I've got a P here and I've got a P here. This S comes below that isometric line but never returns to, because that's what I would expect, something more like what I drew there. Versus ST elevation, which again we're still looking along the same isometric line. And instead of it coming all the way back down to that isometric line, it kind of hangs out above. So ST segment elevation. Now, in my view, that this is a really hard example to see that on. So if I'm trying to get you to understand ST elevation, I'm going to give you something more like this, where it's this tombstone shape appearance, and I don't have to guess about whether or not I have ST elevation. You'll need to know the rules for like how big the ST elevation has to be for your jobs if you're going to work in the ED or ICU. But for basic nursing, again, if I'm going to give you ST elevation, you're going to be able to tell that it's ST elevation. So this is kind of what we would see on a continuous telemetry monitor. I think initially in my cardiac assessment lecture, I talked about how you see changes in that heart rate, and notice how that heart rate is just jumping all around. And that's pretty typical for AFib. The problem with this is that I only get this view of the heart. Now, they're probably an AFib, you're not going to get much more information because it is a dysrhythmia, but it can still detect changes for ischemia in the other leads if you're doing a 12 lead. So if I had a client come in, they had a new onset of atrial fibrillation, I noticed it on the telemetry, I'm going to get a 12 lead as well because it's an acute change, it's a new change, and I need to have the most amount of information to be able to make good decisions. All right. So that was continuous telemetry. This is more of what we would expect to see on a 12 lead. Now, I still picked it out. You can look down here. This is lead 2, but you can still see that this is AFib. Where up here we have lead 3, AVF, AVL, lead 2, lead 1, VR, etc. I don't care, again, if you understand it's anterior, it's posterior, whatever it may be. You guys can find that information online. What I do want you to understand is that this is a one-time view. So even though all I see is AFib on here, it doesn't mean I can't have changes. So if I were to notice some new ST depression, ST elevation, inverted T waves, all that other stuff that we're going to talk about, you would expect to get a 12-lead. Echoes, kind of talked about them already with a TEE and a TTE. One is invasive, one is not, one I can do at the bedside. But it's an echocardiogram. Both of them are called echoes. You just need to understand whether or not I need to be NPO for one, or if they're going to come up bedside and do the other one, I'm going to have to put them on their left side, whatever it may be. We're going to use echoes to look at the valves, the structure, and the motion of blood inside those chambers. So because we're doing that, we're obviously looking at the cardiac chamber size and content. That's going to help me determine like a stroke volume or an ejection fraction. If you have any kind of cardiomyopathies that involve an enlargement of that muscle, so the ventricular muscle and the septal motion and thickness, so the tissue, the myocardium that's separating the left and right ventricles, and the left and right atrium. I can take a look at the ascending aorta. If I think there's a problem with like a stenosis or something, I can check it out there. I can make sure that you don't have any impediments in the ascending aorta. And again, we said we can look at our ejection fraction. You can also do something called a contrast echocardiogram. This is just for all my peds folks. It's a bubble study. We can use it to identify congenital or acquired shunts. And a shunt is just an opening from one chamber into a different chamber, and it's either causing a mix of deoxygenated blood or oxygenated blood. Sorry. So here's kind of, we see the differences. Obviously, the one on the left, the person is doing it here at the bedside. We're looking at the monitor. We're going to record what's going on. And then this one, we will send them down and they will get this transesophageal. It's the better because we're having that probe really close to the heart. Cardiac catheterization. This is going to be for mostly our STEMI clients, our clients that have a long history of coronary artery disease, atherosclerosis. We want to be able to go in and visualize the coronary arteries and look for blockages, look for blood clots. So they're going to go down to the cath lab. If it's a STEMI, they're going to go down emergently. If it's an NSTEMI, they may receive treatment beforehand before we have them in the hospital a couple of days. And then they go down for the cath lab. We can use contrast media, which is going to be injected into a large peripheral artery, and use fluoroscopy. This is the preferred method to visualize your coronary arteries for unstable angina/MI. So obviously clients that are having acute changes in their ST segment. It allows us to see the coronary arteries, to visualize the chambers, the valves, the function, the pressures, the O2 in various parts of the heart. I can get cardiac output, I can get ejection fraction. There is always an increased risk for bleeding from the insertion site. So you can have the development of a hematoma. You need to assess distal pulses to the insertion site. If you're going to use the radial artery, you want to check the ulnar artery beforehand to make sure that it is able to maintain perfusion to your hand. If you're using the femoral artery, again, you're going to check those distal pulses just to make sure that I didn't break something loose and cause a blood clot to turn in to something much worse. There is a small risk of an MI because we are sticking something in your heart into the coronary arteries. It's going to help us determine what we need to do, but because of that irritation, there is a small chance of actually causing an MI, a CVA. Of course, you can have dysrhythmias. Of course, they can have bleeding. Or if I cut off perfusion to the kidney, you can have acute kidney injury. So pre-cath, we want to ensure that the client and the family understand the procedure, assess for allergies to iodine and shellfish, so contrast media. We want to assess renal function prior to, so look at their BUN, look at their eyes and nose, give medications as prescribed. They're going to have to be NPO for a while, 6 to 8 hours, depending on which book you look in. Post-op, we want to get vital signs, listen to heart sounds, lung sounds, assess peripheral pulses, and then it's your job to ensure that the consent is signed. It's not your job to get the consent signed. That's still the doctor's. We're going to do frequent vital signs assessments, and that's all I want you guys to know. And I'm fairly certain that that's the way NCLEX will state it. It will be frequent vital signs. This is way too specific and way too generalized to mean a whole lot. But I do want frequent vital signs. I want to assess the site for bleeding and hematoma formation, kind of at the same interval. If your dressing is saturated with blood, I want you to apply direct pressure. It's either at or above the insertion site. I've seen it both ways in our books. Assess your distal pulses for a thrombosis. Make those documented assessments. We're going to have them on bed rest in a supine position with the extremities straight for a prescribed amount of time following the procedure. We want to make sure that we have access to antiplatelet or thrombolytic agents, depending on what's going on with that client. We want to tell them to avoid any kind of strenuous exercise, and we're going to restrict their lifting to less than 10 pounds for a prescribed amount of time. So I really like this one, this Cath Lab Helpful Hints. It's an acronym. We see a lot with cardiovascular. It's ABCCCs. We see a lot of ABCs. All right. So things that you need to look for: assess for allergies to iodine, monitor for bleeding, apply pressure. If they are bleeding, no heparin, no warfarin, no aspirin, no clopidogrel. Contrast can be administered, although contrast is bad for the kidneys. You can pre-medicate with Benadryl and acetylcysteine if you want. It will help protect the kidneys. You want to monitor their BUN and creatinine levels. If you can't feel a pulse following a procedure, that can be a medical emergency. They've probably now developed a DVT. And then we want to teach them before they come in to get a cath done. Say this is an outpatient kind of thing, that we're going to make sure that they hold the metformin. An exercise stress test is going to be for heart failure. Now, it's not only for heart failure, but what we're trying to do is elicit some sort of response to the stress that I'm going to put your heart under. So for an exercise stress test, I'm going to put you on a treadmill. I'm going to raise the incline. I need you to be able to walk, for at least probably 10 minutes. We're going to gradually increase the speed. And while we're doing that, what we're going to do is we're going to monitor your heart rate. We're going to monitor your telemetry. Those are the things we care about. I don't care that the client gets short of breath. All right. they came in with shortness of breath and complaining of chest pain, I can still do an exercise stress test, because what we're probably looking at is ruling out stable angina at that point. Hopefully, we would like our clients to be able to achieve at least an 85% of their baseline heart rate. We're going to use this information with all the other information that we have to make a decision for our clients. It can reveal some blocked arteries and other damage to the coronary arteries. But notice here what we're saying. The client must have a normal ST segment at baseline. It does not make sense if your client came in for an NSTEMI and they're complaining of active chest pain. That's stuff that I can readily tell. But if I have a new change to that ST segment, I would still want to be able to let the healthcare provider know that it's not what that client's normal would be. There are contraindications, obviously, if it's an acute MI, so we understand that you're going to have changes to your ST segment there. You can have changes to your ST segment with unstable angina. If you're having an acute decompensated episode of heart failure, obviously they're not going to be able to breathe, so they're not going to be able to walk. If they have severe aortic stenosis, uncontrolled hypertension, sepsis, severe asthma, pericarditis, myocarditis, you can have some exercise stress test contraindications. What I want us to know is generally this is probably going to be something that's done on an outpatient schedule. I don't expect to send a whole lot of my students who are admitted students, a whole lot of my clients who are admitted down to or down for an exercise stress test. We can, and we've done it before, but it's just not something I would normally expect. So we're going to begin and have them walk on a treadmill or pedal on a bike. And again, we're going to increase the difficulty. We want them to fast at least 2 to 4 hours before the procedure or per facility protocol. We're going to do this 6-minute walk test. So again, we need to be able to make sure that they can probably walk for at least 10 minutes to get them up and going, to get that heart rate up. We've talked about who it's used for. What we haven't really talked about yet is that if you have a client who can't walk, you can do a pharmacological stress test. Probably the two most common medications are adenosine and bufotamine, and we're going to give those in much lesser doses, but they're given specifically to stress the heart. Dipyridamole, I have never seen given, but that doesn't mean other places don't give it, because my experience in the cath lab is all from one hospital. So we give these medications through an IV line. We want to increase their heart rate. We want to increase their blood flow, similar to the effects of exercises. And then we're still going to monitor for changes in that ST segment. So you will hear us talk about transient ST elevation. So maybe if we're moving along and I have this normal PQRST, and then all of a sudden this next one, I have ST elevation. And then the next one, I have a normal PQRST. And we kind of see that pattern throughout. That's called transient ST elevation. So we are seeing some changes in our ST segment, just not here or here, but I know at least I'm eliciting some sort of change, which is probably going to tell me that they are or do have ischemia or injury. There's just them putting a client on the stress test. You can see that we've got the monitor over here. We're going to have their blood pressure monitored. We're going to have rules, right? I'm trying to elicit something here. I'm trying to get a reaction from you. If I don't and we got your heart rate up, that's great. If I do, then we'll make decisions based upon that new information about what to send you home with. So if we're getting a diagnosis of chronic stable angina, do we want to start you on aspirin, clopidogrel? Do we want to give you a beta blocker? Do we want to give you nitro if you're having episodes of chest pain at home? It's a useful tool to help guide us down those pathways. So we say it is expected for the heart rate, blood pressure, and breathing rate and perspiration to increase. They need to be on continuous monitoring. We need to be able to say that we're paying real close attention, because any symptoms or acute changes consistent with myocardial ischemia suggest that the test should be stopped. Not shortness of breath, not elevated blood pressure, not dyspnea. It's all going to be based upon what that monitoring of the heart rhythm says. We're going to look for ST segment inversions, T-wave inversions, and ST segment depressions. I haven't really talked about T-wave inversions yet. All T waves, drawing it down here at the bottom again, should be upright. So they should go like this. We use inversion instead of upside down because it starts with an I. So if I do have new ST segment or T wave inversion, so I can have depression here or I can have depression there, that is a significant change that is indicative of ischemia, especially if I have them stop and then they go back to this. All right. Your stress test continues until the heart rate reaches a specific target. Or you have chest pain, changes in the ST segment, you have severe shortness of breath, you have severe changes in your blood pressure, severe issues with your heart rhythm. If you feel like you're going to faint, or you're just so tired that you don't feel like you can finish, we can end the test. But we probably didn't get enough information to either make changes to or start you on some sort of program for either chronic stable angina or heart failure or whatever it may be. So here's kind of what we see. We talked about these things specifically. Here you see this S wave. It comes back to the isometric line, and then you have your T wave. So it's normal. Versus down here, I have the P wave, and I have QRS, and then I have a depressed ST segment, so that's right here. And then I have an inverted T wave. So this now is giving me information about what is going on, and this actual little bump right here is what we call that U wave that you don't need to know. But I do see changes in this ST segment depression and T wave inversion. Okay, and here is our other examples. Now, again, I don't expect you guys to just be able to look at this and recognize that some of these look very different from whatever ST elevation that we're used to seeing, while some of them look really close to the ST elevation that we're used to seeing. If I looked at this and went, oh my gosh, how can I tell if that's ST elevation? It would not do that to you guys. It would do something like this, though. Right? That's very noticeable, very big tombstone. That is ST elevation. So we've said this provider is going to stop the stress test if these symptoms appear. They may try to reschedule it just until you feel that you can actually complete the exam. The appointment, all told, should last somewhere around an hour. And again, it's something that's going to be outpatient. And usually, I said 10 minutes, but somewhere between 7 and 12 minutes for actual exercise time. We need to instruct them to report any intermittent claudication. We're going to talk about intermittent claudication when we talk about peripheral artery disease, because this does limit your walking. You can't really walk or do our 7 to 12 minutes of walking if you're having severe leg pain. And of course, you need to tell them that they need to report any chest pain. There are some contraindications. Again, we talked about acute cardiovascular disease, so acute on chronic heart failure, like coming for a STEMI or an MI. They have new angina or untreated angina. And then, of course, we want to make sure that they're not masking the signs and symptoms of the exam. We want to make sure that we're teaching them to hold any of the beta blockers before they come to us. And that is the end. So, just in general, reminder, we will talk about these concepts again. Stick to the basics. Stick to why we use these diagnostic tests. What information do I expect to get from these diagnostic tests? What's a normal finding from an abnormal finding? And we will do really well on